There are a lot of common questions and there's a lot of misinformation. I think a lot of women and also doctors in this field want to know what percentage of infertility is due to male versus female.
About equal portion, male 40%, female 40%, and the 20%, which is probably a combination of the two. And the trick in getting these couples pregnant is by making one person, if there is someone who's subfertile, making the other partner more fertile by either lifestyle or hormonal treatments or antibiotics or and by any means necessary. Like a couple in Oregon I had an interview with, and they were taking a tub bath. They must have a big tub at home. They were taking hot tub baths, even though they had failed IVF a couple of times.
And what's the problem there?
I told them to lower the temperature of the water, and she got pregnant. I know a lot of people have babies who exercise a lot. You always advocate not too much exercise, except everybody's an individual. So a 40-minute exercise for someone such as yourself in good physical condition probably does not kick in the endorphin rush. Exercise for another person might.
And what's wrong with the endorphin rush?
Endorphins have a negative effect on your pituitary gland, which causes lower progesterone levels. There was an elegant study no one remembers because it's so far back. It was also in a medical journal. They wanted to know the progesterone levels every day, estrogen and progesterone, for 3 months on a woman who was a runner. She ran 5 miles a day, 7 days a week, but she had regular periods. So they said, don't run for a whole month. Run 2 miles a day, 7 days a week for a whole month, then 5 miles a day, 7 days a week. Now, some patients will have irregular cycles at 5 miles a day, but she had regular cycles. However, estrogen levels and progesterone levels dropped between the 2 miles a day and 5 miles a day, which means exercise may be good, but not in excess.
What do you think about AMH, anti-Mullerian hormone?
Some of the IVF teams, not all of them, are equating the low AMH with infertility and with quality of eggs, not so much ovarian reserve. I think they're accepting the fact that AMH shows ovarian reserve. Somehow they're getting through to the patient saying, oh, this means that your egg quality is bad. I don't know that they're saying, all the programs are saying that in so many words, because I hope they're not. It only means that, yeah, when you're trying to produce multiple eggs on IVF, you're only going to produce 1 or 2 or 3. And my comment is, what's wrong with 1 or 2 or 3? And don't tell the person she has eggs of a 44-year-old or a 45-year-old, or, so what? So her AMH is low. So doctor, look for other reasons, not that. They're equating it with that reason for their infertility, and they shouldn't do that. I think they are right to tell them, yeah, if you do in vitro, your success rates may not be great. They're on solid ground there, but they're not on solid ground by saying your AMH is low, therefore you have bad quality eggs, therefore you need donor eggs, which is the implication as the conversation goes through between the patient and the fertility doctor. So what? You're 42. So what? Let's get working on finding out why you're not pregnant.
Why do you think people are blinded or rushing to IVF?
The OB/GYN and specifically the infertility group, doctors, are making people run scared. You don't have time for a good evaluation. We have to do your IVF immediately because every month your eggs are getting older. Take 1 month off or 2 months off and try to reassess, is there something else that can be done? I'm not saying don't do in vitro.
Right, you're not against it.
I'm just saying there are other ways first, and then you try.
What do you wish women would know about their fertility? And more than lifestyle and more than getting a good workup, you said something no doctor has ever said to me before.
Okay. Well, I want them to believe that it can happen, that it will happen. You have to have a positive approach. It's not just talk, it's real. For some reason, maybe my success rates are also, especially with patients who have been told you won't get pregnant, is because I empower them and I make them aware that it's very possible. Something's there that has not been found yet. We as a team are going to find it. I also have the patient actually become part of the detective team. I want her to go home and talk with her husband, or have the husband come in and say, what can we do to improve our chances? What's in our power of doing it? Whether it's lifestyle, whether it's adding nutritional supplements. There are a bunch of supplements that could help husband's sperm. There are a bunch of supplements that will help the woman as well.
Are there cases where you would go straight to IVF?
The obvious cases, if there's severe male factor, say there's a blockage in the vas or something, yeah, I have 2 or 3 women right now I'm evaluating. And guess what I'm doing for them? I'm doing their miscarriage workup even before they do IVF.
Wow.
Meaning the miscarriage workup, look for bacteria in the husband and the wife, do the thrombophilia workup. Maybe all necessary, but God forbid.
Right.
I don't want to hear of this patient saying, I sent him off to in vitro and the baby died at 20 weeks or 24 weeks because of clotting factors or killer cells. So I make it very clear to them. I say, I'm not going to be the one to make you pregnant, but I'm going to do my damnedest to make sure that when you are pregnant, you're not going to lose it.